We'll move right on. We're hoping to finish it in less than 20 minutes to talk about acidosis in AKI and CKD. Okay, so we wanted to briefly looking at acidosis in two situations, their characteristics, prevalence, consequence, and the management. And I want to start with a case I was consulted and managed in my last rotation about 2 weeks ago, and the patient was discharged just a few days on the 6th, June the 6th. So if you're looking at the patient, it's a 28-year-old woman who transferred from outside hospital for change of mental status. She had received 8 liters of fluids. More than 3 liters was outside hospital, and in our ED, she received another 5 liters. So if you're looking at her initial lab, she has a creatinine elevation of to 1.2 from her baseline, which is healthy. So she has acute kidney injury, but she also has a degree of lactic acidosis, low bicarbonate, low pH. But on top of that, she has nausea, vomiting. She has a serum sodium concentration of 176. Her osmolality is greater than 450. And she has hypokalemia, potassium 2.7. She also has elevated pancreatic enzymes and the liver enzymes. Her blood glucose level was greater than 600. So that kind of a situation is the patient you see, at least in my practice, acidosis and AKI. So what I illustrate over here is acidosis in AKI in hospital setting. They're typically multifactorial. It varied in the patient presented with either sepsis or all types of intoxication. It could be organ failure. It could be respiratory failure in addition to other organ failure. It could be severe diarrhea, trauma, and many medication intoxications. So in terms of acid causing acidosis in AKI, it could be respiratory, titrable acidity due to respiratory failure. It could be non-volatile acids, which is normal anion gap acidosis, hyperchloremic acidosis, or elevated anion gap acidosis, which is most common in practice, in at least my practice, lactic acidosis, but could also be a number of other acidosis. This is the study. I really don't want to dwell on this study. It's a Mayo experience in the patient on admission with a higher chloride concentration, which because the chloride is in general reciprocal to the bicarbonate. High chloride means low bicarbonate in large number of instances. These patients has acidosis, but these acidosis on admission is not benign because they contribute to the mortality, and that's a significant in-hospital mortality. If you're looking at the patient with acidosis, with anion gap acidosis on top of a high chloride, which low bicarb, which is the dual and normal anion gap and elevated anion gap acidosis, their mortality rate is significantly higher than those with hyperchloremic acidosis, but without an anion gap. So anion gap in every step of the way added hospital mortality. And so if we're looking at a high chloride, low bicarb type of acidosis in the setting of AKI, if there's no AKI, it's very well established that hyperchloremia will cause acute activation of JG, glomerular tubular feedback, and causing afferent arterial constriction. But this effects in the setting of AKI is really unknown. And we frequently say these effects are probably paralyzed in the setting of AKI. But you can bet on these patients with hyperchloremia, they tend to have, in addition to kidney swollen, but also decreased the cortical tissue hypoperfusion in the patient with a setting of hyperchloremia, and especially acidosis, and receive more than 2 liters of IV fluids. And in the patient presented with AKI, but they're still making urine, they have a degree of kidney function with worsening. The chloride is injurious to the kidney is because you would have a decreased renal perfusion, decreased venous return, decreased tissue oxygenation, and really contribute to worsening edema, and worsening edema cause worsening AKI. So hyperchloremic acidosis is in general bad for the kidney oxygen delivery and make the residual kidney function at risk. These are known clinical sequelae of hyperchloremic acidosis, which is decreased urine output, decreased renal blood flow, reduced gastric blood flow. These effects may well be in operation during patient with AKI. There's other effects, for instance, impaired cardiac contractility in the setting of hyperchloremia acidosis, and decreased inotrope, cause hypotension, vascular instability, and these could all be aggravating factors in patients with acute kidney failure. And our patient has a degree of lactic acidosis. So turns out the lactic acid, it's much more than just an energy donor, so to speak, and much far from a dead-end product. It plays a key role in regulating intracellular, extracellular acid-base balance, cell volume, and cell viability. It also regulates the cell metabolic reactions through its unique receptor, G-protein coupled receptor AD1, and has its unique signaling pathways. In the tissue with ischemia, which is mostly occur in patients with sepsis or other acute medical events, through activation of a sodium proton exchanger 1, which is ubiquitously expressed in the tissue, causing apoptosis because the protons exchange for intracellular sodium, and sodium then in turn exchange for extracellular calcium, cause increased intracellular calcium, and unleash effects of apoptosis and causing irreversible tissue damage. And so the lactate would promote wound healing, but in the cancer tissues, the lactate contribute to aggressive cancer behavior. So lactate itself has more short-term effect as well as long-term effects. Acidosis also affects other electrolyte balance, for instance, hyperkalemia. In our patient, she presented with potassium of 2.9. which is counterintuitive. If the patient has acidosis, acute kidney failure, you would think the potassium could be high, but it's not. It could be variable. For patients with a predominant hyperchloremic acidosis, due to the decrease of sodium-potassium ATPase, actually the potassium exit is predominant, cause hyperkalemia in this kind of situation. But if the patient is predominantly lactic acidosis because of a decreased intracellular pH, that cascades to activation of sodium-potassium ATPase. Actually, in these patients, plasma potassium could be low. And that, in addition to osmotic diuresis and other effects in our patients, altogether, you can translate to a high or a low potassium concentration in the setting of AKI and other medical situations. Acidosis in AKI also paralyzes the innate immune response. And we know very well leukocytes fights the potential infection is through, we call the NADPH oxidase. NADPH oxidase is highly rely on the local, we call this phagocytic cup. In the phagocytic cup, you need lots of oxygen. That's why in patients with impaired microcirculation, interstitial edema, these defense mechanism will be compromised. More importantly, if the patient has a low pH, and this NOx will completely paralyzed. And so you have a compromised innate immune response to fight against the infection. So in terms of management of acidosis in the patient with AKI, you essentially want to control and reverse the sources, acid production. You eliminate acid production if possible, and you eliminate exogenous acids. You use bicarbonate or dialysis based on clinical situations. For instance, if the patient has evidence of volume overload, and has severe acidosis, and also AKI is oligoanuric. And that kind of a situation, and we usually offer dialysis to help with correcting the metabolic status. So overall, in patients with acidosis and AKI, our goals is to remove the cause of acidosis as much as you can, and control factors that could worsen acidosis. In the setting of a hyperchloremic acidosis, the worst thing you can do is give some normal saline, because the high chloride is just going to worsen the tissue perfusion as well as worsening acidosis. And serum bicarbonate should be controlled around that level. And in patients with a pH of, you're hoping that patient's pH of greater than 7.2. In patients with lactic acidosis, which is the most common type of anti-gap acidosis in AKI, so if the pH is greater than 7.1, it's really controversial, depending on the causes and a number of several other effects. And data is really, at least 2 pretty old randomized control study did not show any benefit of giving bicarbonate when the pH is greater than 7.1. So coming back to our patients, what we did was correcting, treat the pancreatitis, treat the hepatitis, and gradually coming down on the sodium, get the sugar under control, and eventually she peaked with creatinine up to around 2.5, and gradually with conservative measures down to 1.0, sodium normalized, potassium normalized, and she was discharged just a few days ago. That's just in a nutshell of AKI, acidosis, what kind of typical situation. In the acidosis in CKD is quite different. And this is really a chronic sequela of acidotic milieu. So needless to say, CKD is a global phenomenon, and it's been risen to the 3rd most commonly increased cause of mortality. And if you're looking at acidosis in CKD, it's extremely common. It's one of the earliest complications of AKI, and the occurrence rate of acidosis is proportional to the degree of CKD. So on the patients who are starting on dialysis, 100% of the time they have acidosis. Acidosis in CKD has multiple negative consequences. Acidosis will increase ammoniogenesis and has direct effects on the complement activation and the endothelin activation RAS system, which all creating an inflammatory milieu promoting CKD progression. Not only promoting CKD progression, but also contribute to multiple hormonal resistance, insulin resistance, growth hormone resistance, and altogether causing a situation of increasing protein catabolism, negative nitrogen balance, and bone effects was very prominent, and also beta-2 microglobulin accumulation in CKD. This is a remnant, rat remnant kidney model done by my colleague, Dr. Carl Nass, way back in 1985. And he showed in remnant model, if you give sodium bicarbonate to prevent the occurrence of acidosis, and the mice did much better in terms of it. The rats has much less kidney progression associated with less ammoniogenesis, less complement activation, less interstitial damage. So these are subsequently reproduced by multiple studies. If you take a remnant rat model, giving them bicarbonate to prevent the onset of acidosis on a chronic basis, their GFR is better, and they also has much less endothelium-1 activation and aldosterone activation. What about the human studies? We have CKD stages 2 to 4, followed up 3.9. That's a quick study and demonstrated association of every 1 milliequivalent higher bicarbonate in these CKD patients is associated with 3% of lower risk in CKD progression and progression to end-stage renal disease. There's multiple epidemiological studies draw a strong association of low bicarbonate related to not only CKD progression, but also disease mortality. So we have a good evidence saying in CKD patients, acidosis really has multiple detrimental effects. And what about treatment correcting patients with acidosis in CKD? At least we have 2 trials. They are relatively small, and one trial is followed for 2 prospective randomized sodium bicarbonate and the usual use. And you can see after 2 years, there's significant mortality benefit for these CKD patients treated with bicarbonate. This is another study, 59 CKD patients using sodium citrate, followed by 2 years. There's significant retardation of CKD progression. But these are the 2 trials that we based our practice on correcting the acidosis in patients with CKD. We have multiple trials coming up, and probably the results will coming out next year to look at if these beneficial effect could be verified, confirmed by larger sized study. But current practice is that if the patient has a bicarbonate less than 22, you should really correct these acidosis. You could use mostly sodium bicarbonate tablets. You titrate the doses up to greater or equal to 22. What's the upper limit? Not strongly supported by data, but the common consensus is approximately 26. You really wanted to correct the serum bicarbonate in the range of 22 to 26. So the key point is that acidosis in AKI and CKD, they are very common. They are common, and they're contributing to mortality. In AKI, acidosis occurs in the setting of multiple acute issues. You really have to deal with multiple acute contributory issues in addition to the acidosis in AKI. In CKD, it's completely different. This is a chronic situation. It links to protein catabolism, muscle wasting, bone demilitarization, hormone resistance, impaired hormone secretion, and possibly bone amyloidosis in the setting of AKI. Management is unique for individual patients with AKI, but it's also quite different between AKI and CKD. Correct interstitial edema in both AKI and CKD are very, very important in terms of preservation of kidney function. That's it.